Because of who you are, I give you glory. Because of who you are, I give you praise. Because of who you are, I will lift my voice and say, Lord, I worship you because of who you are. Lord, I worship you because of who you are. Because of who you are, I give you glory. Because of who you are, I give you praise. Because of who you are, I will lift my voice and say, Lord, I worship you because of who you are. Lord, I worship you because of who you are. Because of who you are, I give you glory. Because of who you are, I give you praise. Because of who you are, I will lift my voice and say, Lord, I worship you because of who you are. Lord, I worship you because of who you are.
Good morning, everyone. Good morning. I am Shirley Dixon, president of the Cynthia Cole Circle. It is my pleasure to welcome you to our virtual benefit this morning. So glad to have everyone with us and praying that you are enjoying a beautiful day. This is our 46th annual benefit for our Sickle Cell Foundation. And we're doing it virtual this morning, but we know that everyone is still going to enjoy. The Cynthia Cole Circle was organized in September of 1976 at the Friendship Baptist Church under the leadership of the Reverend Dr. Lewis Johnson, who incorporated the circle into the Department of Mission. This circle was named in honor of Cynthia Cole, an active member who died from complications caused by sickle cell anemia in 1976 at the young age of 21. Our mission statement, which we truly believe in, is the Cynthia Cole Circle has supported the Sickle Cell Disease Association of America, Michigan chapter, for 46 years. We have been blessed with the support of loyal church members as persons, organizations in the community each year to contribute 100% of the net proceeds from our annual benefit. The funds are contributed to SCDAA to further the goal for a cure, promote awareness of this disease, and to assist our parent support with summer camp for children who are afflicted with this disease. They enjoy a week of fun with other children like themselves in a safe environment that caters to their specific needs. As we continue to persevere, God continues to bless our efforts. Now, we would like for you to sit back, prepare your hearts and your minds for a blessing as our program continues. We're going to come forth now with Ms. Marilyn Gripper, who will give you a financial support for the activities over the years of the Cynthia Cole Circle. God bless you.
Good morning. Every year since the organization of the Cynthia Cole Circle, we have been able to donate to the Sickle Cell Disease Association of America, Michigan chapter to help break the sickle cycle. Over the last couple of years, we've been challenged, like everyone else, with the COVID pandemic. Yet God prevailed, and through the use of the Zoom webinar platform, we've continued our mission and have not missed a year to to donate to this worthy cause. With prayers and the support from each of you in 2021, we contributed $3,100. This gives us a cumulative total of $180,840 donated since 1977. Later in the program, you will hear about the many medical advances made to fight this disease. However, we're still on the battlefield. Therefore, your financial support is still needed. You can donate in several ways. If you look in the chat, you will find the link where you can donate online via Givelify, or you can write a check or make a money order payable to Friendship Baptist Church and write on the memo line, CCC Sickle Cell. We want to thank you in advance for your generous contribution and many years of support. We will now be blessed with a song from Reverend Gloria Moore, Associate Pastor of New Calvary Baptist Church. Have a wonderful afternoon.
Good morning, everyone. I'd like to first thank the Cynthia Cole Circle for inviting me to take part in this very important ministry. The psalmist said, "Oh, give thanks unto the Lord, for he is good, for his steadfast love endures forever." I thank God that he allows us to experience his love day by day. God tells us to show our love to our neighbors. May we do that, demonstrating our love for Christ, and therefore through us, others will experience God's love for them. Once earthly joy could song, peace and rest. Now thee alone I see, give what is best. This all my prayer shall be, more love, O Christ, to thee, more love to thee, more love to to thee, more love to thee, more love to thee. This is Father's will. My love, cries to thee. More love to thee. More love to Amen.
Thank you, Reverend Moore, for that beautiful, beautiful selection. Thank you so much. I have the honor of introducing today's keynote speaker, the Dr. Wanda Whitten Cherny. From an early age, Dr. Wanda Whitten Cherny was exposed to the sickle cell movement. Her visionary father, Dr. Charles Whitten, recognized the need for national awareness and support of sickle cell disease research when he co-founded the National Association for Sickle Cell Disease, now known as the Sickle Cell Disease Association of America. Dr. Whitten Cherny has over 30 years of experience providing high quality and compassionate care at the Comprehensive Sickle Cell Clinic at Children's Hospital of Michigan. Dr. Whitten is proud of the Detroit Public School System. She won first prize for her project on sickle disease at the Durfee Junior High School Science Fair. Dr. Whitten Cherny completed her undergraduate work at the University of Michigan and attended medical school at Howard University. She received her pediatric residency training at Children's Hospital of Michigan and spent a year in their hematology oncology fellowship. Dr. Whitten Cherny currently serves as the CEO and medical director of the Sickle Cell Disease Association of America, Michigan chapter. The association serves as the coordinating center for the newborn sickle cell screening program for the Michigan Department of Health and Human Services and is responsible for confirming testing, education, and initiation of life-saving treatment of close to 2,000 newborns. Dr. Whitten Cherny prides herself on patient engagement and education. As a pediatrician, she understands the values of empowering and equipping families with coping skills in order to tackle the potential realities of sickle cell disease. She is known for her down-to-earth personality and sense of humor. I can attest to that. She has 2 children, Simone and Cameron. When she is not advocating for the sickle cell community, she enjoys movies, traveling, and ballroom dancing. Please, everyone, help me welcome Dr. Whitten Cherny. Thank you for being with us.
Rashonda, thank you so much for that introduction. I really appreciate it. There are a couple of things that before I get started. One is that my disclosure is I have an allergic cough and I have these spasms of coughing. So if one comes up during the talk, I'll have to mute myself and cough and then come back, but we're gonna fight through this thing and hopefully it won't happen, but we'll see. You know, the other comment that I just wanted to make is when you say I spent a year in a hematology fellowship. Yes, I spent a year in a hematology fellowship and I left the fellowship because I was taking care of kids with cancer. And in a year, I had been to 9 funerals and I had spoken at 3 of them. And I decided that this was not the best thing for me because there's something called detached concern that I wasn't able to kind of wrap my head around, and it was just making me way too sad, right? And so then my last rotation was in the comprehensive sickle cell clinic that my father started, and I was like, oh, here I'm home, and look at all these kids and they're doing well, and you know, I can help them with their routine care and so forth. But I will tell you that in the last 2 months, I've been to 2 funerals, because now as my patients are getting older, they're reaching their lifespans. But one of the funerals was for a 14-year-old. So, and I actually spoke at that funeral. And, you know, I just want to say that this is a part of what keeps me motivated to keep doing the work that we do at the SCDAA Michigan chapter. I also want to mention to those of you who may not know that at the SCDAA Michigan chapter, we have the Cynthia Coles Inspirational Hall, where we have a picture of Cynthia and we have pictures of other warriors surrounding her. And the last thing I want you to know is that something that we plan to add, and I've been working with Ms. Dixon on, is having a picture of Mrs. Maxine McBride, because of all the work and all the dedication to the Sickle Cell Disease Association. So we're going to get a framed picture of her with a little post that says the work that she's done for our organization, and we'd like to go and visit her and show her the picture so that she knows that she's going to not ever be forgotten in terms of the SCDAA-MI. So with that, I am going to share my screen, and I'm going to click on this, and then I'm going to say share. And then I think we've got that. And now I just have to go to the slideshow from the beginning. Okay, Rashonda, did I do okay on that? Everybody can see my screen? Okay, so I am going to now start my little timer, because there's nothing worse than people that keep talking for way too long. I don't want to pay attention to my time. And I plan to talk for about 25 minutes. I hope that you find the information so engaging that you really forget about the time. Okay, so I've frequently been asked to do the research update. And so this is really going to be an extended research update, but some of you may be joining us for the first time, so I really feel that it's important for me to give you some background. And even if you heard the background before, I think it's important to kind of update you. So just for a moment about history, and that is that in 1910, James Herrick described these peculiar and elongated sickle-shaped red blood cells in an intelligent Negro of 20. And I always thought it was interesting that he had to include the word intelligent, because he was using the word Negro as if the two didn't automatically go together. So that was something interesting. And that first patient was Walter Clement Noel. He was actually a dentist. He was born in Grenada, and he came to Chicago to go to dental school. And then he actually went back to Grenada to practice dentistry. But we see in the literature that there's this article that describes this poor, unfortunate man had leg ulcers and an absent spleen. He was a runaway slave. And we feel that this was probably one of the first people who had sickle cell disease in the United States, and that was in 1846. Now, one of the key researchers, Linus Pauling, was the one who first described sickle cell disease as a molecular disease in 1949. But I want to show you here some other things that Dr. Pauling thought were important. And he thought that carriers should not be allowed to marry each other, because we need to get rid of this disease. And he thought, in fact, that they should have a tattoo on their forehead that said you had sickle cell trait. And maybe even better, we should tattoo it in Braille on their abdomens. So I just kind of like to point out that whole attitude that kind of still exists today, that our parents go to the emergency room and they have a child with sickle cell disease, and they're told, didn't you know you could have a child? How could you bring a child into this world? You know, and the thing is, I don't think I have any patients that wish they were never born. And our second mission at the SCDAA Michigan chapter is to allow parents to make informed decisions about childbearing. Not that if a family is at risk for having a child with sickle cell, that they not have children, or that if they do get pregnant, they abort the child if they have sickle cell, but so that they know what all of their options are, so that they can not have a child with sickle cell disease by accident, only by choice. So we know that it was Vernon Ingram that figured out that it was just this single point mutation from glutamic acid to valine that caused red blood cells, the hemoglobin inside red blood cells, to line up and what we call polymerize. And that's what causes the red blood cell to take on that unusual shape. And when I was at Howard University, they were saying, oh, it's just that single point mutation, and we're going to have a genetic cure for this disease in 5 years. Well, I graduated from Howard in 1983. And here we're almost at 2023, and we still don't have that genetic cure that was supposed to be 5 years away 50 years ago. And so I also want to mention the fact that even though we described it in the United States in 1910 for the first time, that we've known that about sickle cell disease, particularly in areas of West Africa, where it's been given these names, and this name here means bone chewing. So we know about the pain, and patients still sometimes describe this pain as bone chewing, and that the names are frequently repetitive syllables. And that makes you know that this is something that kind of comes and goes, that sometimes patients are sick and then get better, and then they're sick again with a pain crisis. But we also know in areas of Africa that the lifespan is only to age 6, the average lifespan, because of the poor care. And we also know that having sickle cell trait protects you from getting malaria. And so if you have sickle cell trait in an area where there's a big problem with malaria, you're more likely to survive and have children. And that's how the sickle gene was allowed to grow when it came about by mutation. So you would think that if you overlay a map of malaria over one of sickle cell disease, that they would, just be exactly overlaid perfectly. But what you see here in the United States is, while we no longer have malaria, we do have sickle cell disease. And whenever you see sickle cell disease in a place where you don't have malaria, how it got there is always by migration. And in the case of the United States, that migration was the forced migration of the transatlantic slave trade. So when they brought us over to build this country for free and then told us to just forget about it, we brought our sickle cell genes with us. And I also always like to mention that the Black Panthers were really known for their work against police brutality, but they spent a lot of time trying to educate people about sickle cell and did sickle cell testing. And my father was involved with that group. And so I just always like to acknowledge the Black Panthers for their work in sickle cell. And just a really quick overview, what is sickle cell disease? Well, the red blood cells take on that unusual shape. And then what happens, and here, a lot of people don't even know what a sickle is. So when I'm doing my family education sessions, I always say, well, here's the sickle and here's what it's used for. Sometimes the kids will say to me, why don't we call it crescent cell disease or banana cell disease? But sickle cell disease is named after something that you may not intuitively know what it is and why it's named that. And so, but the biggest problem is that these red blood cells are sticky and hard and fragile, and they block blood vessels. And of course, it's the red blood cells that carry oxygen to all the different parts of the body. So if the blood vessel gets blocked, then that part of the body can't get oxygen, and that causes pain, and it also causes organ damage. And the other big problem with having red blood cells that are shaped like a farmer's sickle is that they break down. They're fragile. They break down early. So if you have sickle cell disease, your red blood cells only survive in the circulation for about 2 weeks. And that's what causes the anemia. And the anemia is what causes the fatigue. So particularly in adult patients, we see a lot of problems with fatigue. Now, in terms of talking about health problems, we know that every part of the body needs oxygen. And so sickle cell disease affects every part of the body. And when I do my family educational sessions, I always emphasize the fact that every child with sickle cell disease is different. So I always show this slide of a snowflake, because every snowflake is different, or at least so they say. And so when I'm educating families about complications, it can be very overwhelming, because I don't know which child is going to have which complication, and recognizing the complication early on helps the child to do better. And so I have to tell families about all the complications, but I want them to kind of put the attitude we have is, let's deal with problems if and when they arise, and know that education is very empowering. And so you know what to do for your child if that complication does occur. So one of the biggest problems with sickle cell disease is the increased susceptibility to infection. And that's been a problem in terms of COVID-19, because our patients are immunocompromised. And so we were really concerned that we would have a huge problem with COVID-19, although our patients have done fairly well with that. But that's the reason that we use penicillin from the time the child is born until they turn 5 years old, to decrease their chances of getting a very serious bacterial infection. But of course, we know that the hallmark of sickle cell disease is pain, and these episodes called a pain crisis. And if people know anything about sickle cell disease, that seems to be the thing they know. Isn't that painful disease? And Dr. Wally Smith, who is a leading research in sickle cell disease and is the author of the Pisces study, which is a huge study in terms of understanding pain in sickle cell disease. And one of the things that Wally helped us to understand is that when you see a patient in the emergency room for pain or in the inpatient setting, what you're really seeing is the tip of the iceberg. And I'll talk about this a little bit more in the next couple of minutes. But patients do not want to come to the hospital because they know that they won't be treated well. So when you see these patients, that's the tip of the iceberg. But what we're seeing under here is a tremendous amount of suffering because of the resistance of people to actually seek care for their pain because of their concern that they won't be treated properly and they'll be disrespected. And the other big thing that Dr. Smith showed us is that 30% of patients with sickle cell disease have pain every day. And I should say 30% of adults with sickle cell disease. And that requires opioids or narcotic therapies every day. And with this opioid pandemic, epidemic, then we have issues with our patients getting the proper medications that they need to treat their pain, which is very real. And so just very briefly, again, increased susceptibility to infection, this yellow color to the eyes, which is called yellow jaundice, which can then lead to gallstones, problems with the joints called avascular necrosis, high blood pressure in the lungs called pulmonary hypertension, problems with the back of the eye. Since again, it's a disease of blocked blood vessels, a blocked blood vessel in the brain is a stroke, blood getting trapped in the spleen, and then these horrible, painful leg ulcers that are so difficult to treat and cause problems for a lot of our older patients, particularly men. And so I'm just trying to give you a view of how this involves every system in the body. And one of the things that we see is our patients grow more slowly and usually reach puberty later. And I just always think this is a fascinating slide because these are maternal twins. And so they grew in the same uterus, right, in the same womb, and they live in the same household and they're eating the same food. And I'll let you guess which one has sickle cell disease. So how do you get it? Well, you get it if you get a sickle gene on the sperm from your father and a sickle gene on the egg from the mother. And usually the most common way to get sickle cell disease is that both parents have sickle cell trait. And so this sickle sperm comes together with this sickle egg and the child then comes out with sickle cell anemia. And so what we say is every time a couple who has sickle cell trait has a baby, there's a 1 out of 4 chance that baby will have sickle cell disease, a 1 out of 4 chance that they'll be normal, and a 2 out of 4 chance or a 50% chance that the baby will have sickle cell trait. So with each pregnancy, there's actually a 75% chance that the child will not be affected with sickle cell disease. So let's talk for a minute about the challenges that our patients or that the community really faces. And of course, the first one is awareness. The people don't know about sickle cell disease. And unfortunately, one of the things I say a lot is that people don't know much about sickle cell disease, but what they do know is wrong. They know a lot of the myths, like, for example, you die by the time you're 21, or it's just a Black disease. Well, it's not just a Black disease, but it is a Black disease. And the fact that it is a Black disease causes a lot of problems because of institutional racism. Young people don't know their trait status, so I've already talked briefly about that, but in newborn screening, when we reach out to families to tell them that their child has sickle cell disease, frequently the mother will say, well, I know I have the trait, but the father doesn't have the trait, so my baby could not possibly have sickle cell disease. And then we would bring the father in for testing, and of course, then he would have sickle cell trait. And so that actually can cause a disruption in the family, because for a moment, the father might actually be thinking that, this might not be my baby. Another challenge is that for over 20 years, we only have one disease modifying therapy, and we don't have a universal cure. The average lifespan for an individual living with sickle cell disease is 30 years shorter than the average lifespan for the general population. And then I think really for me, the biggest problem is pediatric versus adult care, the difference in how the care that kids with sickle cell disease receive as compared to adults with sickle cell disease. So in terms of that particular problem, one of the biggest issues is that we don't have enough adult providers who are, number one, capable of, or number two, willing to take care of our patients. So they get poor treatment in the emergency room. They're labeled as drug seekers. We know it's well documented in the literature that patients with sickle cell disease wait longer to get pain relief or pain medications than people that come in with cancer pain. There are some doctors that want to run lab tests on the patients before they get any pain medication. And those lab tests, there's no lab test that tells you about pain, right? And so and then they'll come back and say, well, we ran your labs and they're all normal, so you couldn't possibly be in pain, and so that just doesn't make any sense. So one of the things that ignorance is rampant, even among physicians. And one of the things that's really distressing for me is to hear from a patient that they're in excruciating pain, but they feel like they have to take a shower, shave, change clothes before they can go to the emergency room in order to look presentable so that they, can try to get adequate treatment. And once again, there's the difficulty of obtaining these essential pain medications because of the opioid epidemic. And because we don't have places for our patients to go, we really have limited access to, I'm going to talk to you about some of the newer treatments, but if you don't have a doctor to go to, how are you going to get these treatments? And for a long time, Children's Special Health Care Services, which is the supplemental insurance company for the supplemental insurance program for people that have special healthcare needs, it would cut off at age 21 for people with sickle cell disease, where it covered cystic fibrosis and hemophilia through the lifespan. So when you talk about healthcare disparity, then that's a real issue. So I say that we don't really use Webster's dictionary anymore. If anybody wants to know anything, I think that they always Google it, and so one of the things that I say is if you Google healthcare disparity, what should come up is a picture of a man living with sickle cell disease and a woman with cystic fibrosis. Now, let me offer you some proof. Okay, so even though back in 2006, when Dr. Smith conducted this study, there was an estimated 30,000 people with cystic fibrosis in the country and 80,000 with sickle cell disease. But let's look at the prevalence. Hold on just one second. Oh, hold on. Can I do this? Let me go back. Okay, now if you look at the total support for sickle cell disease compared to cystic fibrosis, you can see the huge difference in funding, and that's a part of the healthcare disparity. Now you might say, okay, well, that was back in 2006. Well, what's going on now? Okay, so look, you can see once again the difference in the funding for cystic fibrosis versus sickle cell disease. And also what you can see is that during this time up to 2018, there were 4 new drugs for cystic fibrosis and only 1 new medication for sickle cell disease. So, and that one medication that we had for sickle cell disease was hydroxyurea. And hydroxyurea is actually a repurposed cancer drug. And so even though it works well, it decreases pain episodes, it decreases acute chest syndrome, it decreases the need for transfusions, and people who take it live longer. When you talk about the sickle cell community and individuals living with sickle cell disease, one thing that is that they are very skeptical, right? And I think for good reason, because of the history of poor treatment, and I think because of the things like the Tuskegee experiments, and I frequently have patients tell me that they don't want to be treated like guinea pigs. and I hear them tell me, I don't have cancer, so I'm not going to take that medicine. It wasn't made for the sickle cell community. It was made for people with cancer. And so we have difficulty getting people to take hydroxyurea, even though it's a really good medication. Now, I don't know how many of you remember that commercial. This is your brain. This is your brain on drugs, where they fry the egg, you know. Well, this is the slide that I use. Like, this is your body on hydroxyurea, before hydroxyurea. If this is your body on hydroxyurea. Any questions? I mean, because you can see the fewer sickle red blood cells, even this red blood cell, even though it's starting to sickle, it sure doesn't look as bad as this red blood cell, right? And the other thing that you can see is that there are more red blood cells. So taking hydroxyurea actually increases the number of red blood cells. It decreases the anemia. So that's just another reason that it's a very helpful medication. So let's talk about the good news, because there are really good things happening in the sickle cell community now. One of them is that we have 3 new medications. In 2017, we got Endari, which is a naturally occurring amino acid. So people were much more willing to take it because it's not a cancer drug, and it decreases pain, and decreases hospitalizations, and it decreases acute chest syndrome. And then we called November of 2019 the November to Remember, because we got 2 new medications. We got Oxbryta and we got Adequil. And Oxbryta actually causes hemoglobin to hold on to oxygen tighter. And that means that the red blood cells won't sickle as much. And this medication is from a company called Global Blood Therapeutics. And its initial name was GBT 440, because it was the 440th molecule that they looked at to try to find something to help sickle cell disease. And the CEO of this pharmaceutical company, Ted Love, came out of retirement because he wanted to do research in the sickle cell space. He wanted to run clinical trials to try to help patients with sickle cell disease. And they only do clinical trials in sickle cell disease. And then we have Adequil, otherwise known as crizolizumab, and that's an IV medication for patients that are 16 and older, and it's known to decrease pain episodes. So now, instead of having the 1 drug that people were afraid to take, we have a total of 4 drugs, and there are lots of clinical trials and lots of other medications in the pipeline that are going to be helpful to our patients. Now let's talk about the cure, because as I said, there is no universal cure for sickle cell disease. Now we do have a cure, it's bone marrow transplant. So what happens is, when I'm doing my family educational sessions, I always show the bone marrow. And because all of your blood cells come from your bone marrow, so if we're able to get bone marrow from your brother or sister and give it to you, then that would, of course, cure your sickle cell disease. It wouldn't change your genes. You would still pass on that sickle egg or sickle sperm to your offspring, but it would cure the symptoms of sickle cell disease. But the problem is, a person with sickle cell disease, their bone marrow is already full, right? Because they're constantly trying to make red blood cells to replace the ones that are being broken down early. And so what we have to do is first get rid of the patient's own bone marrow, because before we can give them someone else's bone marrow. And we do that with chemotherapy and irradiation, and all of the side effects and long-term complications that come along with having to get chemotherapy and sometimes irradiation. And then in addition to that, because the bone marrow is the source of your immune system, then if you get a bone marrow transplant, not only can you reject the bone marrow, but the bone marrow can reject you. So even though it is a cure, it is not a universal cure, and it is not without long-term side effects and complications. So we worry about that. I'm trying to check my time here to make sure I'm okay. Okay, so far so good now. So one of the things I like for people to know is that we can store the stem cells of a baby that's born. Say a family already has a child with sickle cell disease, and the next child may have sickle cell trait or may be normal, because once again, there's a 75% chance that that next baby won't have sickle cell disease. And we can actually store that baby's stem cells for free, so that if at some point the family opts to have a bone marrow transplant, we have a source of stem cells to do that transplant. And then I, of course, have to talk about the Cure Sickle Cell Initiative, where the NIH announced that we would have a cure, a genetic cure for sickle cell disease in the next 5 years. And of course, I mentioned that in 1983, we were saying we're going to have a cure for a genetic cure for sickle cell disease in the next 5 years. So we're still waiting for that cure, and there's still lots of problems with that. But in this case, what happens is we get the bone marrow from the actual patient who has sickle cell disease, and then we genetically modify that bone marrow, right? So we're going to genetically modify that bone marrow and then give it back to the patient. But once again, we still have to get rid of that patient's own bone marrow, right? We still have to do that. And, you know, when you talk about genetically modifying someone's bone marrow, you have to think about this skeptical patient population, right? And basically, we don't want to eat genetically modified food. And now we're talking about genetically modifying people and how frightening that must be. And we don't know what the long-term complications of this might be. We do know that we have lost one patient to leukemia, and we have 3 patients that have attempted this gene therapy that have what we call myeloproliferative disease, which frequently turns into leukemia. So once again, the long-term follow-up is really important. And I feel like, you know, maybe we could handle this community the same way we handle HIV, in that we don't have a cure for AIDS, right? But we know that people living with AIDS are living a better life because we have really good treatment that we can start from early on in the diagnosis. So if we have really good treatment for patients with sickle cell disease that we can start, and we diagnose sickle cell disease at birth, maybe that's really the way to go in terms of providing really good treatment rather than these risky cures until we have a better idea, get a better handle on long-term follow-up for the genetic cure for sickle cell disease. Now, I want to talk about some of the really important things that are going on in Michigan. And as you know, I never talk about sickle cell disease without talking about my father, Dr. Charles Whitten. He met with a total of 4 presidents. I think that my mother might have finally found the last picture when he met with President Nixon, and actually was instrumental in establishing the Sickle Cell Treatment Act of 1972, which I am proud to say I was a part of getting it reauthorized in 2018 when President Trump actually signed it into law. And now we are actually working on trying to get more money. We have $500 million. We have $5 million behind it now. We're trying to get up to the 20 million that we actually asked for. And when it was reauthorized, instead of this for it just being for sickle cell disease, they insisted on making it for sickle cell disease and other heritable blood disorders, which we thought was really a problem because the major other heritable blood diseases already have a lot of money. But it seemed as though they just didn't want us to have our own treatment act that was just for sickle cell disease. So we had to take what we could get. So now that Sickle Cell Control Act is actually for sickle cell disease and other heritable blood disorders. Now, something that's really exciting that's going on in Michigan is Governor Whitmer's proposal for change. And, you know, one of the things that I have to say is that the Michigan Department of Health and Human Services has always been on the side, has always worked hard to improve the lives of individuals living with sickle cell disease. Governor Whitmer actually had a task force to look at healthcare disparity, because, you know, when everything came about with COVID-19, it just, you know, there was a brighter light shining on healthcare disparity. Even though it's always been there, people started paying more attention to it. I actually applied to be on that task force, and I didn't quite make the cut, but I was asked to give a presentation about healthcare disparity to the task force. And I think they really listened, and along with the work of the Children's Special Health Care Services Advisory Committee, we got Governor Whitmer to come up with this proposal for change. And one of the most important things that it did was allow us to expand coverage for our patients past age 21. So instead of Children's Special Health Care Service insurance cutting off at age 21, it now will go through the lifespan. And that means that we can bill higher for the services that we provide. And we know that money talks, and we know that we have about an 85% Medicaid population, which is part of the reason it's difficult to get care for our adults, because Medicaid pays low and slow. So now actually we can bill Children's Special Health care services. Her proposal for change also included $690,000 that was to come to the SCDAA, but of course, this is going to be just a way that we get funding straight from Medicaid as opposed from the Michigan Department of Health and Human Services. So this did not increase our budget at all, but it kept our budget stable. And then there was, it ended up actually being $400,000 that was available for different treatment centers to apply for to improve care for adults with patients with sickle cell disease. And actually only 3 clinics applied, and they all got $100,000, and they'll get $100,000 a year for the next 4 years. So hopefully that's going to make a big difference in how we can care for our patients. And then the other thing is that we have a true champion in Representative Ronnie Peterson. And he actually has now, we're working on getting a license plate, a sickle cell license plate that we're hoping you all will, when we have it put together, that you might be interested in having a sickle cell awareness license plate. And then in addition to that, there is the Michigan Enhancement Grant. And another one of our champions is State Senator Sylvia Santana, and she raised $750,000 for a Center of Excellence in Detroit for adults living with sickle cell disease. And this is actually what I live for now. I wake up thinking about this, I go to sleep thinking about this. We have a total of $1 million so far because Global Blood Therapeutics has promised us $250,000. The Wayne County Executive, Warren Evans, has also promised us an additional $1 million. And we are really working at establishing the Charles F. Whitten Center of Excellence for Sickle Cell Disease in Detroit. And if we get that done, I want all of you to come to the ribbon cutting, because it's going to be a true medical home for adults with sickle cell disease. And what does that mean? That means they'll be able to see a hematologist or a blood specialist. They'll be able to get their primary care in the same place where they're getting their sickle cell care, because they have to go to the doctor frequently once a month just for their sickle cell care. And then, okay, so now you've got to go to their primary care doc, then that's, too much, so if they can get it, if there's one-stop shopping. We also want to have mental health support, because we know that there are significant mental health issues in every community, but particularly in the sickle cell community, because of the challenges that our patients face. There are some people that feel that a number of our patients actually have PTSD, because their lives have been interrupted. Every aspect of their life is stressed by this unpredictable, excruciating, indescribable pain. And so that's a concern. We want to have social work services. We want to have alternative ways to manage pain. We want to have acupuncture. We want to have yoga. We want to have biofeedback. We want to be able to just, we don't want to take away the patient's narcotics, but we want to make it so that they require less narcotics. They can be gradually weaned off their narcotics because they're on better disease-modifying therapies. So we're really hopeful. I'm really feeling as though this is going to be huge in terms of changing. We don't want our patients to just live longer and longer. We want our patients to live better and better. And I do need to mention a young Black physician, Dr. Patrick Hines, who has started a company called Functional Fluidics, where he studies the way that red blood cells function. And he can actually put a patient's blood through a synthetic blood vessel and measure how sticky the red blood cells are and how they adhere to the wall of the blood vessel, which is part of what causes a pain crisis. And then he can actually treat that blood specimen with a medication and run it through that synthetic blood vessel again and see how it has helped. And so this will allow Michigan to be at the forefront of actually changing the way we take care of patients with sickle cell disease. We don't have to kind of experiment and, okay, try this drug or try that drug. We can take blood from the patient and actually help us determine what would be the best medication for that patient. And I think that having Michigan be at the forefront of that innovative therapy would just really be fantastic. So I don't know if most of you know about the DeQuinder cut. I would imagine that you do, but this is what it used to look like. And this is what it looks like now. And I tell you that this is what care for sickle cell disease. Let me go back here. Okay, let's see if we can actually do this. Okay. This is what care for sickle cell disease used to look like. And I think we haven't quite made it to this. We've made a lot of progress. We still have a long ways to go, and we're still working really hard to get it to look like this. And what we really want to do is we want to stop managing complications in sickle cell disease, and we want to start managing wellness. So I'm going to end with the fact that the fight continues, the passion continues. I feel as though I feel my father's energy all around me. I feel his spirit dancing around me and saying, Wanda, good job, keep up the good work, SCDAA Michigan staff. We're really working hard to improve the lives of individuals living with sickle cell disease. And a lot of you may have heard already that on June 19th, there was a landmark article published in the New England Journal of Medicine, which was the basis of establishing newborn screening, that June 19th is World Sickle Cell Day, and June 19th is my birthday. So there's a picture of my father holding me. I don't think it was necessarily on June 19th, but I was born on World Sickle Cell Day. I really feel as though my calling is to do what I can to improve the lives of individuals living with sickle cell disease. And with the help of all of the people, all of my staff at the SCDAA Michigan chapter, and all of the people that I work with around the country and around the world, we're really making some positive headway. So I'm really happy to be able to share that with you today. And I don't know, I guess you can see on my t-shirt that says Sickle Cell Matters because the pain is real. And I want to let you know that Monday is the last day to click on this link and order a t-shirt and wear it on June 19th. We're shining the light on sickle cell. So the t-shirt comes with a glow in the dark kind of necklace, like those little tubes that kids use on Halloween. So you wear the necklace and you'll wear the shirt and you'll shine the light on sickle cell. So I invite you to go to our website and click on that link and join us in raising sickle cell awareness. So that's my shameless advertisement. And I just want to thank you for listening and for coming to the Cynthia Coles Banquet, and once again, acknowledge Friendship Baptist Church for their long dedication to the Sickle Cell Disease Association of America Michigan chapter. And it's been a pleasure talking to you, and I hope you enjoy the rest of your weekend. So I will stop sharing my screen so that we can, okay.
Well, Dr. Cherny, Dr. Wanda Whitten Cherny, thank you, thank you, thank you. Words cannot express how much we appreciate the information that you have just shared. You kind of gave me a little tidbit and said you had exciting news, but this is just overwhelming, so informative. And we want to thank you for all that you have presented to us today, and know that your work will continue, that you continue with the support of Friendship Baptist Church and the Cynthia Coles Circle. Just thank you. I'm lost
It
for
is
words.
my pleasure. Awesome. My pleasure, Ms. Dixon.
That was awesome. And our Reverend Gloria Moore, Songbird, beautiful. You've blessed us. More love to thee. And that's exactly what we need today. More love, more love, more love. With all that's going on around us, there couldn't have been a more appropriate song shared with us today. And we thank you. And we appreciate the continued support of the Sickle Cell Disease Association of America that we work so closely with. And we want to say thank you, thank you, thank you, and a double thank you to our supporters of our benefit. Each and every, over these last 46 years, we've had the support of our Friendship Church family, friends, the community. You've just blessed us and supported our efforts. And we just say thank you again. And I want to take this moment to also acknowledge the members of the Cynthia Coles Circle at Friendship Baptist Church. We work diligently in everyone's heart each year that we come forth to have our benefit. Everyone puts forth their best effort. And we have some wonderful, wonderful, wonderful troopers, a part of our team, because we all work together. We can't do, one person can't do this. We all work together. We want to say a special thank you to Inetta Cosper, Charlotte McBride, Diane Wicker, Maxine McBride, Rashonda Orta, Marilyn Gripper, Jacqueline Kendricks, Ellen Williams, and Sheila Jackson. Thank you to you all. God bless you, and may he continue to keep everyone safe. We're going to have our benediction now from our own pastor of Friendship Baptist Church, Reverend Dr. Samuel White III. He will bring us our benediction. And once again, everyone be blessed. And please remember to make your contributions. The information is, I believe, is in the chat. If you have any questions regarding how you might submit your contributions, please feel free to call the church office. 313-833-1072 is the church office, or continue to go to our website to find additional information. Thank you and God bless. Pastor White.
Let us pray. Our Father, who is in heaven, who is a God of love, who is Jehovah Rapha, the Lord our healer, we thank you for all that you have done and all that you are doing. We thank you for developing Andare, Oxybrita, and Davio that will bring healing and comfort to those struggling with sickle cell. We thank you for all the bone marrow transplants and the stem cells. We thank you in advance for the cure of sickle cell and gene therapy. Thank you, dear God. We are so very grateful for all the physicians, nurses, scientists, health aides, therapists, researchers, social workers, clergy, churches, SDA, people of goodwill, and the Cynthia Cole Circle for providing the money, the resources, the information, the treatment, and the care. We ask that you would continue to let the blood of Christ, the blood of Jesus, bring grace, strength, wisdom, hope, healing, and above all, love for all of us. It's in Jesus' name we pray. Amen.